Welcome back, everyone. Welcome back, everyone, to our second day of Borneo Ophthalmology update. Good morning. Without further ado, I would like to invite Dr. Vanitha Ratnalingam, consultant ophthalmologist and corneal surgeon in Oasis Eye Specialist, to present her talk on recurrent corneal erosion.
Hi everyone, I'm Dr. Vanitha, consultant ophthalmologist and corneal surgeon at Oasis Eye Specialist. I'd like to thank the organizing committee for the kind invitation to share my thoughts on recurrent corneal erosion syndrome. I have no financial disclosures. So by definition, this is a chronic relapsing disease of the corneal epithelium and epithelial basement membrane that's characterized by the repeated breakdown of epithelium, resulting in symptoms of pain, tearing, sensitivity to light, and in chronic cases, corneal scarring, which can lead to visual changes. The highest prevalence tends to be in the 3rd to the 5th decades with a slight female preponderance. It can be very frustrating for the patients. They're often debilitated by the pain and visual deficits. I have a patient who's had recurrent corneal erosion for 4 years, and she tells me, "Doctor, I'm so scared to go to sleep because I don't know whether I'll wake up with pain again." And she actually had a paper cut to the eye 4 years ago. So we know that trauma is one of the most common causes of recurrent corneal erosion, associated with about 45% of cases. The incidence following trauma to develop RCE is about 1 in 150 cases. Corneal dystrophies, especially epithelial basement membrane dystrophy, is also a significant risk factor, with about 29% of cases having EBMD. A combination of trauma and EBMD can be seen in about 17% of cases. Other causes include stromal dystrophies, like lattice dystrophy, which can give you recurrent corneal erosions, keratoconjunctivitis, Zika, dry eyes, meibomian gland dysfunction, nocturnal lag ophthalmos, where the eye is partially open and the cornea tends to dry out, as well as diabetes mellitus. Now we know that an inadequate epithelial basement membrane adhesion to the underlying Bowman's membrane causes the epithelium to shear off when the patient wakes up in the morning and opens their eyelids. The commonest site to be affected is the inferior half of the cornea. So the histology is quite interesting. There are a variety of adhesion complex defects that have been observed, but I just want to go through these 3. There's an absence of basement membrane in hemidesmosomes. I think we know that one. But there's also a reduplicated basement membrane, or what you get is a multi-layer basement membrane, as you can see here. So this sort of inhibits or makes it difficult for the basal cells to migrate to the epithelial surface, and they form a loculation of connective tissue in epithelial cells. And when they do break through and make it to the surface, then they actually erupt and you get a foreign body sensation. So the diagnosis of this disease is made mainly from history. The history is quite typical. So you get a sudden onset of sharp pain. In micro erosions, you might just have sharp pain, and then it gets better after a few minutes, whereas in macro erosions, usually it's quite painful with redness and tearing, blurring of vision. You want to differentiate these two in terms of treatment. So with patients with micro erosions, they do tend to have less severe symptoms but more frequent symptoms. So do remember to ask for a history of trauma in the involved eye. On slit lamp examination, we can see a variety of findings from epithelial microcysts, which are actually quite difficult to see. So you want to look hard for those because sometimes all you have are epithelial microcysts. In more obvious findings include either a grayish patch on the corneal epithelium or a large area of epithelial detachment. So you can get a large epithelial defect here, lots of loose epithelium. This is easily seen. Whereas when you have got small areas of erosions, you may not notice the loose epithelium unless you stain the cornea. Sometimes gentle pressure on the cornea through the eyelid will show some wrinkling of the loose epithelium. The adhesion test is easy to do with a cellulose sponge. Just gently touch or rub the epithelium, and if it moves in like a sheet-like manner, then you know the patient's got recurrent corneal erosion. It's also important to examine the fellow eye for signs of corneal dystrophy. So OCT is not required in the diagnosis of these patients, but I'd just like to show you some interesting findings. So this is a normal OCT where the uppermost or the topmost hyperreflective line is the tear film, and then you've got the epithelium, the basement membrane, and the Bowman's layer. So here you actually have got breaks in the epithelium. You can see these epithelial breaks which are filled up or covered by the tear film. In this second diagram here, this arrowhead actually points to an area of intraepithelial hyperreflective inclusions that you can see down here. And just beside it, this asterisk here, in this area, the basement membrane is actually very irregular and absent in certain places as compared to this area here where there's actually a nice white line to demarcate the basement membrane. And in the lowermost picture, you can see a hyperreflective line in the anterior stroma, suggestive of some scarring. So here you actually see what I mentioned earlier, the multi-layer basement membrane. So you can see this extra white line, a hyperreflective line within the epithelium. That is the multi-layer basement membrane that has formed. So now that we've diagnosed the condition, we want to move on to treatment, but it's important to assess the patient so that you can individualize their treatment. As I mentioned earlier, someone with micro erosions, they may sometimes just resolve on their own, so they don't really require surgical treatment. But a medical treatment or conservative treatment is mostly eye drops, lubrication. You can teach your patients to actually not to open their eyes when they wake up in the morning, at least not to do that first thing. Just keep some artificial tears beside their bed, and as soon as they wake up, just reach for that and just drop some drops into the corner of their eyelids, and just allow some of it to trickle inside, and that will actually help to reduce the frequency of recurrent corneal erosions. Of course, with acute cases, then you'll need to do patching, or you give them some cycloplegia or lots of topical lubrication, some antibiotics as well. Yeah, often you can use a bandage contact lens for about 6 weeks. Other options include autologous serum or MMP inhibitors. Punctal occlusion can be considered in patients with dry eyes. Now, the punctal plugs actually help to increase retention of tears in the ocular surface, which helps with lubrication as well. Now, where conservative treatment is not an ideal option or has failed, then surgical treatment includes epithelial debridement, anterior stromal puncture, phototherapeutic keratectomy, or diamond burst superficial keratectomy. So for epithelial debridement, this is really just removing the loose epithelium to promote healing from the healthy edges. And the devitalized epithelium, as we know, inhibits restoration of the intact basement membrane and inhibits the recovery of tight epithelial stromal adhesions. So this can be done easily under local anesthesia. So it can be removed either manually with a number 15 blade, or you can use alcohol delamination. So this would need, you could use an alcohol weld and just put some alcohol in there just for a few seconds over the patient's corneal epithelium. Just remembering that you don't want to spill any because it's quite toxic. So just keep being careful of the limbal stem cells. It's also important when you are using the number 15 blade that you don't want to damage the underlying stroma. This can be followed with topical antibiotics and a bandage contact lens. So another option would be anterior stromal puncture, and this is really to enhance epithelial adhesion to the basement membrane by scar formation. So this can be performed under local anesthesia at the slit lamp using a bent 27 gauge needle. So fluorescein is used to define the affected area, and you want to treat the affected area and then extend 1 millimeter into the normal epithelium. It's important to avoid the visual axis, of course, because you're going to get some scarring, and then follow up with bandage contact lens and antibiotics. Now, the micropunctures are thought to incite a fibrocytic response, which stimulates basement membrane production, and we know that it also induces some scar formation. The success rate is quite good if you choose the ideal candidates. Yeah, it's about 80%. Advantages, of course, of this method is that it's easy to perform, it's not expensive, very minimal discomfort because you're not actually removing the entire epithelium. The disadvantages, though, is that it may result in subepithelial scars, and it's not recommended if the erosion encroaches the visual axis. Okay, so as I mentioned, the ideal candidate is really someone with localized erosions, because you can't be doing, micropunctures everywhere. So localized erosion where you can just do treatment in that specific area. And for something that's maybe or sort of more diffuse disease, you can consider either phototherapeutic keratectomy or a diamond burr keratectomy. So with PTK, you're using an excimer laser to ablate the Bowman's membrane to prepare a smooth bed for the epithelial cells that migrate over. And sort of this helps with new hemidesmosomal adhesion complexes. So the ideal candidate would be someone with, larger area involved, moderate to severe disease. And even someone who is myopic, you can do PTK with photorefractive keratectomy at the same time. Now here we're going to remove the epithelium, and then we are going to use a 7 to 8 millimeter diameter laser beam, which is programmed to ablate 6 microns. So that would still be within the Bowman's membrane. The success rate is good, 74 to 100%, but it's more successful in trauma compared to corneal dystrophies. And this is probably because corneal dystrophies tend to extend further to the periphery, whereas you're only treating 7 to 8 millimeters a diameter with this laser beam. So you're not really going out into the periphery. As I mentioned, the advantages is that, you're removing corneal tissue with precision, you're not damaging the irradiated areas. The large beam cross-section allows simultaneous treatment of a large area. So it's quite quick. The disadvantages, though, is that you can get refractive changes, of course, pain because the epithelium is removed. It is expensive, and the excimer laser is not easily available. This is unlike epithelial debridement and diamond burr treatment of the recurrent corneal erosion, where the loose epithelium can be debrided either manually or with alcohol. And then this can be treated with a diamond burr. So this doesn't go down too deep. You're just basically getting the anterior Bowman's layer in just it's easy to perform. The advantage is that you can actually go out into the periphery. In patients with epithelial basement membrane dystrophy, you generally have a fairly good outcome. So the results are comparable to PTK in head-to-head studies. It's simple, it's not expensive. There may be less haze and fewer recurrences, although in these studies there isn't any statistically significant difference. And of course, it can be used over the visual axis as compared with anterior stromal puncture. Now, the side effects that you can see in both of these both PTK as well as diamond burr polish includes corneal haze and scarring. Of course, the epithelium is removed, so there's always a risk of infectious keratitis. And decreased vision, sometimes that's actually due to a refractive change that can be seen with these procedures. So I'd just like to end by saying that, with the armamentarium that we have nowadays, it's easy to treat these patients. The prognosis is actually quite good. Of course, patients should be educated in the signs and symptoms of recurrent erosion. So if you've got a patient with trauma, you may want to tell them that there is a risk of recurrent corneal erosions, and so they know what to look out for and to seek medical attention as soon as necessary. So thank you very much for your kind attention.
Thank you, Dr. Vanitha, for the very interesting talk on RCE. Next, we have Dr. Ching Wang. He is he's a consultant ophthalmologist and glaucomatologist. Currently, he's in Hospital Ipoh. We would like to invite Dr. Ching for the next talk.
Hi, good morning. Thank you for the giving chance to share with you regarding anti-glaucoma medication and its related corneal toxicity. This is my disclosure. So, for glaucoma, the first-line treatment of glaucoma is topical anti-glaucoma, and it's lifelong commitment for daily eye drops. And it is estimated that more than 40% of patients require more than one time of instillation per day. If you look at this typical patient's eye, from far you know that they are glaucoma patients because they are on chronic anti-glaucoma medication, and this is a proof of they are compliant to medication. And frequently they can tell you that they have foreign body sensation, they are in pain and discomfort, they are stinging sensation, they are itchy, and there's a blurring of vision, some of the patients. So if you carefully examine their eye, you can find out that there's a lot of dry eyes on the ocular surface. They have this superficial punctate keratitis as well as tear film instability. This has been known that when the glaucoma eye drops increase the frequency, you have increase in percentage of severe dry eye symptoms. All of this is either due to the toxicity from the preservative itself in the eye drop or from the side effect of the medication itself. Why we need preservative in the eye drops? This is because the multi-dose containers which we need to repeatedly use, and is subject to bacterial contamination. It has been shown that the preservative-free medication, once has been used more than 10 hours, there's a risk of contamination to the content. So, what are the choices of preservative we have? We have benzalkonium chloride, or commonly called as BAC or BAK. We have alcohol, we have parabens, and even chlorhexidine. However, among those, BAC is the most common one. Why BAC? BAC is because it has the surfactant properties, which is bactericidal as well as bacteriostatic. It has low allergenic properties to the eye of the human, and has a good safety profile. However, the bacteriostatic and bactericidal doesn't stop at bacteria only. It also causes all this destruction to the cornea cells of human. It causes ocular surface toxicity, ocular surface disease, and to some extent it causes early surgical failure post-glaucoma surgery. So it causes tear film instability, it causes inflammation, and it also causes epithelium damage of the cornea. From the list, you can see that most of the medication is actually preserved with BAK or BAC. Some of them with prurites, and some of them with soft zia, and some of them is with preservative-free formulation. So, what preservative in anti-glaucoma medication causes to the cell? It causes impaired cell proliferation. It causes apoptosis, it causes inflammatory response, and even DNA damage. For these cells, it shows how apoptosis occurs. On the left column is the corneal cell, which is treated with 24 hours of various solution. Whereas on the left is 24-hour treatment with another 24 hours for recovery. The first two rows shows control, which only using a buffer line as well as preservative-free medication. It shows very few apoptosis cells. It's almost similar before and after. Whereas for 0.05 BAC, it shows a moderate apoptosis, especially on the superficial layers, where when the concentration of the BAC increase, is more apoptosis occur. So the second slide shows the inflammation. When in the corneal cells with preservative-free medication as well as buffer, there's no changes in terms of inflammation. However, the inflammation increase in 0.005 BAC up to 0.01 BAC. For a higher concentration of BAC, more than 0.015%, the reduce in inflammation of the cells. This is not because of cells not inflamed. However, this is due to erosion has occurred and the biomarker for inflammation has been reduced. The third slide shows how it causes or it affects cells proliferation. So for all the preservative-free medication, no effect on proliferation of the cells. However, for cells treated with preservative-free, all of them shows reduction in cell proliferation, and is most of them restricted to the basal layer. So how about tight junction of the cells? For zonular occludence and tight junction proteins of the cells, in the normal control and preservative-free, it looks present and normal. However, for those treated with preservative, it shows disappearance of the zonal occludence as well as tight junction, and in a varied stage, some of the nucleus is actually become shrink. It also causes DNA damage in a higher concentration. For instance, in this study, 0.005 and above of preservative of BAC, it caused DNA damage. For precorneal mucin, on the left box in blue is a normal control. Via electron microscopy, you can see that the mucin layer is normal. Whereas on the left side is treated with BAC 0.01% for 5 minutes, 15 minutes, and 60 minutes. For a short duration of BAC, the mucus becomes thin. For 15 minutes, it's nearly total loss. Whereas in 1 hour, there's total loss. There's no longer attachment of mucin to the epithelium layers because it has been detached. So how about endothelium? From this study, it shows that the endothelium proliferation viability is high for preservative-free medication as compared to those with preservative. In terms of corneal nerve, the corneal nerve with preservative shows low density as compared to those without. In terms of conjunctival epithelium, for baseline and 12 months, the control shows not much of difference. However, for timolol with BAC, the conjunctival epithelium looks less. How about allergy? It do cause allergy. It's either from the medication itself or from the preservative. All anti-glaucoma do cause certain extent of allergy to the eye. What happened is, you can see from the picture, it causes conjunctiva and periorbital hyperemia, it causes chemosis, it causes lid edema, and even red eye. So, from all the pictures and all the examples, we know that there are some difference in between clinical trial setting drugs and the real world. In clinical trial, we only test one medication at a time. As compared to the real world, most of the patient has more than one medication. And in the real world, patients using the medication for many years, they are pre-existing ocular surface disease as well, and it comes and goes. This shows that the clinical safety testing is not always really fit to the real world what we can be seen. So, for glaucoma patient, when we put them on anti-glaucoma medication, we have to balance up the IOP lowering effect for the disease, and we need to look at how severe is the side effect to maintain the quality of life. We need to balance the ocular surface disease to choose whether to continue with medical treatments or we proceed with surgical treatment. However, what is other alternative we have? We have other type of milder preservative. We have polyquat, we have Solzia, we have Purax. In terms of polyquat, it's a derivative from BAC. Compared to BAC, it's less epithelial cell penetration and it has a larger molecule. If you look at the pictures on the right side, the polyquat maintains cell in the good normal shape as well as appearance as compared to BAC. For Solzia, from the study, it shows that the cell's viability is higher as compared to other types of preservative. And Purax, patients will have a better experience in terms of symptoms compared to the conventional preservative. So, how to avoid ocular toxicity? There's various methods. We can use preservative-free medication. We can use slow-release implant. We can combine the formulation. We can do lasers, and we even can do some surgery for all these patients. So, for preservative-free formulation, definitely patient will have less pain, much more comfort, less foreign body sensation, stinging sensation is less, much more improved dry eye, less tearing, and less itchiness of the eye. As for combi formulation, we can combine 2 medications in 1 bottle. Means if patient has 4 medication, we combine them, it becomes 2. It's actually reduced the total frequency of instillation of eye drop, and inadvertently it causes reduction in toxicity. The example is the formulation is the mixture in between timolol and prostaglandin analog, and carbonate anhydrase inhibitor with alpha agonist. And this is the new technology in glaucoma, where we have a sustained release implant. We implant the bimatopros implant into the anterior chamber, which can last for almost 6 months. In terms of lasers, the light study, which has been published in the Lancet previous years ago, suggests it as a first line for POAG as well as ocular hypertension. And options of surgery. For mild to moderate glaucoma, we can use minimum invasive glaucoma surgery, where we insert a small or miniature of new instrument or new devices into the eye. For severe glaucoma with high IOP, we can proceed with trabeculectomy, or even we can put in a glaucoma drainage device. So, what is the new in drug delivery system in coming days? We will have contact lenses coated with slow-release medication. We might have phonics-based silicone rings, and we even have drugs-related punctal plugs. So, with that, thank you very much for your kind attention.
Thank you for the interesting talk. Now we will move on to the topic, contact lens-related diseases, which will be presented by Dr. Rosilah Binti Mohammad, consultant ophthalmologist and corneal surgeon in HKL.
Assalamualaikum and good morning everyone. I would like to thank the organizing committee for inviting me to participate in this ocular Borneo update. I'm Dr. Rosilah from Hospital Kuala Lumpur. I'm going to share with you some of the contact lens related problems. Well, contact lens is worn by millions of people, and it is estimated worldwide contact lens users to be about 140 million. In the United States, It is more than 45 million, and 2/3 of these are females. Generally, contact lenses are quite safe and well tolerated. However, there are certain conditions that give rise to contact lens-related problems. Some of these include abrasions, infections, contact lens-induced keratopathy, giant papillary conjunctivitis, dry eye, hypoxia, and last but not least is corneal warpage. Abrasion is a breach of the corneal epithelium, and this stains well with fluorescein. It can be a potentially serious complication in contact lens wearer. For this reason, look hard for evidence of corneal infiltrates, as this can signify early infection. Treatment basically is with adequate broad-spectrum antibiotic coverage, and these patients should be followed up early within days. As far as possible, avoid the use of topical steroids. Infiltrates are caused by white cells, particularly neutrophils, which migrate from the limbal vasculature or tears. Steroid infiltrates is a hypersensitive response to bacterial antigen or the chemicals used in lens care. It can also be due to mechanical trauma, whereby the contact between the contact lens and the cornea disrupt the corneal epithelium. Other than this, it can also be due to tight lens, hypoxia, denatured lens deposits, or poor lid hygiene by the wearers themselves. This condition resolves spontaneously with cessation of the lens wear. Some cases may need topical antibiotics and steroids. If at any point the diagnosis is uncertain, treatment should be that of bacterial keratitis. It is very important to differentiate between steroid infiltrate and infected infiltrate. Remember the acronym PEDAL. It is probably infected if there is presence of moderate to severe pain or photophobia associated with overlying epithelial defect, presence of mucopurulent discharge, presence of significant anterior chamber activity, and the location of the infiltrate is at the central or mid-peripheral part of the cornea. However, this is not absolute, because small peripheral infiltrate can still be infected even though it is sterile looking. It can be still culture positive. Next is microbial keratitis. This is the most serious complication that can happen in contact lens wearer. Generally, this is caused by microtrauma or mainly due to poor compliance or poor contact lens hygiene. It can happen in any type of lenses used, such as soft lenses, rigid gas permeable lenses, or autokeratology. Over the years, the risk factors associated with microbial keratitis in contact lens wearers have not changed much. These include overnight use of daily wear soft lenses, showering or swimming with contact lenses, poor contact lens hygiene, lack of hand washing, reusing multipurpose solution, or failure to use proper rub and rinse technique for lens cleaning. Microbial keratitis can be caused by a variety of organisms, which can include bacteria like Pseudomonas, fungus, or acanthamoeba. Pseudomonas is one of the commonest complications that can happen in a contact lens wearer, and it can get worse within 24 hours. Fungal infections are quite common. The examples are Fusarium, Aspergillus, and also Candida. Between the years of 2004 to 2006, there was an outbreak reported regarding fungal keratitis associated with contact lens solution. It has been reported in Hong Kong, Singapore, as well as in the United States. Gossack and his co-workers have reported an outbreak of Fusarium keratitis associated with contact lens use in the northeastern United States. It was so severe that 40% of the patients require therapeutic corneal transplant. Initially, the source was thought to be water in sinks or the patient's showers. However, later, the Center for Disease Research found that the outbreak was due to multipurpose solution Renu, which was then the product was withdrawn from the market in May 2006. Next is contact lens induced keratopathy. It can begin superiorly and can involve the entire cornea. It is characterized by superficial corneal scarring associated with surface irregularities and limbal stem cell deficiency. It is also precipitated by dry eye and redundant conjunctiva. This is due to allergic or toxic response to the preservative, especially thimerosal, which was used in contact lens solution. Treatment for this condition is to discontinue the lens wear, lots of lubrication, and normally the resolution takes up to about 6 weeks after the cessation of the lens wear. Giant papillary conjunctivitis, also known as contact lens peripheral conjunctivitis. Patient will come with symptoms of itchy eyes, gritty sensation, burning associated with redness, and increased mucus production. Normally, they have poor tolerance to contact lens wear. On examination of the palpebral conjunctiva, you might find a remarkable papillae on the tarsal plate. This complication is one of the commonest complications that can happen in contact lens wearers. So please consider this in every visit of the patient. The treatment includes to discontinue the lens wear until the signs and symptoms subside, or if necessary, change to a different type of lens. It's very important to remind or advise the patient to adhere strictly to the lens care regime. In the early stages, frequent use of lubricating drops might help, but later, if the entire cornea is involved, or if the symptom is persistent or recurrent, mast cell stabilizers such as sodium permanglicate might be useful. Dry eye is defined as a multifactorial disease of the tears and ocular surface, which results in symptoms of discomfort, visual disturbance, and tear instability. This is often accompanied by increased osmolarity of the tear film and inflammation of the ocular surface. There are certain facts regarding the association between contact lens and dry eye. Contact lens users who experience dry eye may not have dry eye disease. Those patients with dry eye disease experience increasing discomfort with the contact lens use. Some of the contact lens users are asymptomatic, and some might find that their eyes were unbearably dry upon wearing the contact lenses. Whatever is the association between contact lenses and dry eye, contact lenses have always been found to cause or exacerbate dry eye symptoms. The symptoms of dry eye increase later in the day with duration of the contact lens use. It tends to get worse in dry environments such as in a closed air conditioning room. It is also aggravated by activities involving prolonged use of eyes, like what we are doing now, virtual meetings, virtual classes, and endless work with the computers. The clinician should look for evidence of other causes of dry eye, such as blepharitis, meibomian gland dysfunction, or evaporative dry eye disease. The normal treatment includes warm compresses, good hygiene, lots of tear lubricants. In severe cases, you might prescribe cephalosporin or pantoplex. Oral omega-3 fatty acids have been advocated or suggested by many and reported to be beneficial. However, its information regarding efficacy in dry eye disease is still limited. Contact lens can also induce hypoxia. This can occur to any layer of the cornea, namely the epithelial, the stroma, as well as the endothelial layer. Acute edema can occur in patients using daily wear lenses overnight. They typically present with complaint of blurred vision and pain. Treatment is contact lens holiday. That means stop wearing contact lenses for a few days to weeks. Sometimes cycloplegic drug or antibiotic might help. If it doesn't resolve, low dose topical steroid might be started. And these patients need to be followed up closely. Contact lens-induced hypoxia can also occur in extended type where contact lens users, they complain of pain and epiphora. On examination at the slit lamp, especially by retroillumination, you might find microcystic epitheliopathy or fine epithelial cysts. The cysts may increase in number, and it takes about 6 weeks to resolve with discontinuation of the contact lens wear. Chronic hypoxia can occur with overwear of any type of lenses, namely low gas permeable lenses, early generation of hybrid lenses, or high-powered daily wear soft lenses. It is characterized by the presence of superficial or stromal corneal vascularization associated with or without infiltrates and lipid deposits. The patient normally presents with mild to moderate redness with reduced tolerance to contact lens. With time, there will be extensive vascularization of the cornea and results in cornea scarring. Sometimes you might even be able to see intracorneal hemorrhage. Again, the treatment is to reduce or discontinue the lens wear, and if necessary, the patient may be refitted with gas permeable or looser type of contact lenses. Long-term contact lens wear can actually alter the corneal topography or corneal curvature, giving rise to a condition known as corneal warpage. It can be a transient change, but it can cause a significant refractive errors, and typically patient will present with spectacle blur. On topographic examination, you will see bilateral symmetrical superior flattening of the cornea associated with dramatic inferior steepening, which might mimic keratoconus. However, these changes will normalize over the next few weeks following the cessation of the contact lens wear. This is a table just to show you the time to recover from corneal warpage based on the lens type. It is the longest in extended wear soft lenses, which take about 11.6 weeks, and the shortest or fastest in daily wear soft lenses, which takes about only 2.5 weeks. In conclusion, we all are aware that actually contact lenses have various therapeutic and beneficial indications in ophthalmology. The benefits include it offers natural field of view, it has less reflection and less aberrations compared to glasses, it is light. On the other hand, glasses are easy to use. You put it on and off you go. It's like touch and go cut. And it has got frame varieties that you can choose and to fit your face or your style. The complications vary from mild to severe to blinding. That's why early diagnosis is very important, and to treat the patients appropriately in order to optimize their outcomes. With that, I thank you.
Thank you, Dr. Rosilah, for the very informative talk on contact lens related diseases. Before we go to the Q&A session, just a little bit of a housekeeping announcement. For session 6, the last session later, we'll be starting at 10 o'clock without any break. All right. So we invite all the speakers for some Q&A question. We have a few questions from the audience. The first question is for RCE topic for Dr. Vanitha. In your practice, when do you perform debridement in RCE cases? Earlier or only when there is a poor improvement with medication? When should you perform it?
Hi, Balan. Thank you for the question. When should you do debridement? Personally, I do debridement if the patient comes for the first time with an acute attack to see me, and there's already loose epithelium, then I would debride the epithelium. I think if they come with, symptoms, or sometimes they come with very mild symptoms, they just say, doctor, I woke up and there was a sharp pain. After an hour, now I feel better. And when you stain, there is just a small area of loose epithelium. For patients like that, I would probably, go with lots of lubrications if this was, one of the first few times. But of course, if they're having recurrent attacks, then you might want to think of something else besides debridement. And if you're going to debride, the other thing you want to remember is you should really put a bandage contact lens on and keep it on for a while, because often when the stroma is, there, if there's damage, if it's trauma and there's damage to the basement membrane and the Bowman's layer, fibronectin actually grows across to try to form a new layer for the epithelial cells to migrate. And this actually takes longer for these epithelial defects and for the adhesion complexes to form, compared to a regular corneal abrasion where there is, you still have an intact basement membrane.
Thank you, Dr. Vanitha.
Hi,
Now
Dr.
we'll move on
Vanitha.
to
Can I ask you something?
Hi, Liew, sure, go ahead.
Yeah, actually, I also have a recurrent corneal erosion patients that always have recurrence, even though we did some diamond burr polishing and epilectomy, things like that. Will you suggest them to go for this PTK after they did the surgery, still have a similar symptom?
Okay, I'm guessing this must be a chronic problem. Is that right? Yeah, so usually it's the chronic ones, like I mentioned earlier in my talk. I have a patient, I've done quite a few diamond burr polish, and to be honest, I've only had one patient recur, and she's apparently had recurrent corneal erosions for 4 years. I would say the problem with PTK is you actually extend to the periphery in less than you would with a diamond burr polish. So you actually get more across with the diamond burr polish. So if you look at head-to-head studies, diamond burr polish actually has a little less recurrence. I think it's about 95 to 97% compared to PTK. And we assume this is because PTK doesn't really go out to the periphery, so it's not so good for epithelial basement membrane dystrophy. Having said that, so for my patient, I actually repeated the diamond burr polish. I would probably advise you to try with alcohol delamination as well, and then diamond burr polish. And if that fails, yes, go ahead with a PTK, only because the PTK gets down to, really polishing the Bowman's layer. So you're actually polishing about 6 microns of the Bowman's layer to try to get that nice smooth layer. I can't guarantee you that every patient will recover. I mean, of course, if you look at the literature, there are patients who don't recover, but, I think it's definitely worth trying PTK if you've done a diamond burr polish twice and, with alcohol delamination and it still failed.
Yeah, I totally agree with you. Actually, I think I would not suggest my patient to go for the PTK, because my patient, I noted her previous lesion and the new lesion, sometimes it's in a different place. And then I also noted he has some epithelial, subepithelial opacity, which point to the basement membrane dystrophy. So maybe not so suitable for the PTK. So maybe it will still recurrence in somewhere else, even though after we do the LASIK.
Well, one thing you might want to consider if you are doing PTKs, you can always do PTK and then just repolish the periphery. And let me know how it goes.
Thanks for the suggestion.
Thank you, Dr. Liew, Dr. Vanitha. I always tell Dr. Liew when he's operating, the diamond burr is my favorite ophthalmology tool, actually. We have another question.
Okay, so this is for Dr. Cheng. There are some patients immediately after the installation of anti-glaucoma, they will complain of redness and burning sensation. So how long do we wait before switching to other anti-glaucoma agents?
I think this rate and discomfort is more towards preservative or medication itself. If let's say all the resources is available, I think we just shift, because as the long time we wait, we tend to see dry eye. The most common one you would see, most of them have dry eye in certain extent, but really they feel discomfort, I think just switch if let's say you have a preservative-free medication.
Thank you, Dr. Cheng.
Thanks.
Dr. Cheng, there is another question from the audience for you. This question says, this is, I think, a patient of theirs. Patient has many allergic to anti-glaucoma and failed Trebec. What else can I do?
Yeah, I think it suggests once medication cannot use, I think Trebec already failed. It's either we go for second Trebec if permeable, or else we go for glaucoma drainage device. We can put in a tube, we can implant the tube in. Yeah. Thanks for the question.
Thank you, Dr. Cheng. Next question is for Dr. Rosilah. Will you suggest patients to do LASIK if they had contact lens corneal warpage?
Hi, thank you for the question. As I've mentioned in my presentation just now, corneal page actually is a temporary condition. So after you stop wearing, ask the patient to stop wearing contact lens for a few days to weeks, then you would follow them up to see, it will come back to the normal curvature. So if let's say the patient is high myopia and she wants to go for a LASIK procedure, she has to stop using contact lenses for a long time, and then this has to be reassessed later. So it's okay, because LASIK is good for young patient who is highly myopic, but while they are using the contact lenses for short-term period, this should be discontinued to assess the condition of the cornea, because corneal page is a temporary. So once you stop, then it will come back to the usual curvature or contour. Thanks.
Thank you, Doctor.
Another question for Dr. Vanitha. Hi, Dr. Vanitha. What else would you do if all surgical intervention failed in RCE?
Wow, I haven't had that happen yet. I think if everything fails, then probably the best thing you can, you'd have to counsel the patient. These patients are very upset and frustrated. Hopefully they are one of those mild or micro erosions, because they don't really wake up with such debilitating pain in the morning. What I did mention earlier in my talk is that you can actually learn to wake up in the morning and not open your eyes first thing in the morning. Just reach for your artificial tears and just apply a few drops in the corner, let it trickle in, gently move your eyes, and before you actually open the eye. You might find that some patients over time they just recover on their own. So yeah, if we can actually minimize this kind of erosions in the mornings, then hopefully over time they will just recover on their own.
Thank you, Dr. Vanitha.
I think there's one more question. This is for Dr. Rosilah as well. This is from the audience. Dr. Rosilah, in your practice, is there any role for anterior segment OCT to diagnose corneal hypoxia in contact lens usage? Do you ever do that?
Unfortunately, we don't have that kind of anterior segment OCT. We have OCT for the posterior segment, but we don't have for the anterior segment. So no, so we are not practicing that for now. Maybe in future.
Is it Dr. Liew?
Okay. So I think this question is directed to all speakers, especially Dr. Rosilah. In your opinion, should the government or MOH regulate the dispensing of contact lens usage?
Regular. My opinion. I think it will be a bit difficult, because it has to involve a lot of authorities, not only the government. It must involve the MOH, ministry, the doctors, physicians, private governments, So all of these organizations should have, a proper meeting and channel and discuss about this proposal, I would say. I dare not say anything about it, but at my level, I don't think I can do that. But, it will be of a good idea, but it has to involve a lot of organization and authorities, including private and government side. Okay.
Yeah, I hope the head of service will hear that. It's beyond our control actually, but maybe the upper level they can do something.
Yeah, right. That's right.
Thank you, Dr. Rosilah, Dr. Liew.
Thank you.
Okay, with that, we thank all our speakers for answering all the questions. So next, we have still about 7 minutes, but since there's no more questions from the audience, is it okay if we continue with the next section? It will be, the next speaker will be Dr. Liew, our cornea consultant from Hospital Queen's E Sabah. Dr. Liew, you can proceed.
Hi, A very good day to all of you. The topic I would like to share today is Cytomegalovirus endothelitis. In 1982, Cordodos first described endothelitis as a specific form of corneal endothelial inflammation, characterized by localized corneal edema, keratitic precipitates, mild anterior chamber reaction, and often endothelial dysfunction. Generally, corneal endothelitis means inflammation of the corneal endothelium. The etiology is extensive and, although commonly viral, may be medication-related, procedural, infection, environmental, or systemic disease-related. It was classified into four morphological appearances, which are linear, sectoral, deciform, and diffuse form of endothelitis. This picture was taken from Moshifa's review in 2019. Picture A shows linear endothelitis with linear capice appearance. Picture B shows sectoral endothelitis with localized sectoral corneal edema superiorly. Picture C shows deciform endothelitis with crown lesion or cone-shaped lesion at the endothelial level. Picture D shows diffuse endothelitis with diffuse distribution of capice and generalized corneal edema. In 1954, the human cytomegalovirus was first described by Margaret Smith. It infects majority of the population during childhood. CMV is a ubiquitous lymphotrophic herpes virus, commonly found in the latent infection and rarely cause severe systemic disease in healthy individuals. In 2006, Koizumi from Japan first reported corneal endothelitis that caused by cytomegalovirus in healthy individuals. In his report, CMV endothelitis was unilateral eye involvement, presence of capice, cone-shaped lesion, and localized corneal edema. This picture was taken from Koizumi's first report of CMV endothelitis. Picture A shows sectoral corneal edema with cone-shaped lesion and linear capice as pointed out from the white arrows. Picture B shows cone-shaped lesion from retroillumination when the cornea was less edematous. Wang from Taiwan also reported similar case of CMV endothelitis in 2009. The eye was also presented with cone-shaped lesion with underlying capice and localized corneal edema. CMV endothelitis is hypothesized to have similar pathophysiology as HSV endothelitis. Infection can be reactivated intermittently along the trigeminal ganglion and shedding the virus particle into anterior chamber via the nerve branches that supply trabecular meshwork and uveal tissue. Therefore, concurrent trabeculitis may lead to high IOP during the course of CMV endothelitis. CMV endothelitis extensively reported in Japan, Taiwan, Singapore, and Hong Kong. There were not many cases reported in the Western countries. Tohami from France reported CMV-related anterior uveitis as Posner-Grossman syndrome or chronic anterior uveitis, but did not observe any endothelitis. CMV endothelitis seems to affect Chinese and Japanese mainly. It occurs in variable age group, but averagely above 60 years. It has male predominance and mostly unilateral eye involvement. CMV endothelitis also occur in the post-corneal transplant patients such as post-penetrating keratoplasty, DSEC, and DMAC. The clinical symptoms can be eye pain, eye redness, reduced visual acuity, glaring, and photophobia. The clinical signs included circumciliary injection, mild anterior uveitis, localized corneal edema, cone-shaped lesion, linear capice, or ocular hypertension. Koizumi from Japan Corneal Endothelitis Study Group has come up with the diagnostic criteria in 2015. They have classified CMV endothelitis into typical and atypical form. The typical CMV endothelitis is come with positive CMV DNA PCR plus the cone-shaped lesion or linear capice. The atypical endothelitis is come with positive CMV DNA PCR plus two of the following signs: recurrent or chronic anterior uveitis, high IOP, or evidence of endothelial cell loss. The differential diagnosis of CMV endotheliitis should include HSV or VZV endotheliitis as they have similar clinical presentation, but coin-shaped lesion or linear capes almost exclusive for CMV endotheliitis. Bear in mind deciform endotheliitis is different from deciform stromal keratitis, which occurs in HSV stromal keratitis. CMV-related hypertensive anterior uveitis may look similar to Posner-Grossman syndrome or fused heterochromic iridocyclitis. Indeed, some of the previous idiopathic cases now has been linked to CMV. CMV endotheliitis in post-corneal transplant have the similar clinical features of endothelial graft rejection. Endothelial rejection also have linear capes, which is known as Codados line. However, anterior uveitis in endothelial graft rejection is more extensive. There was a case series of Chi Soon-Pak in 2013 has reported CMV endotheliitis may have more extensive pigmented capes and usually arranged in coarse clumps in the trough of the descemet fold, as well as absence of corneal vascularization. PCR of aqueous fluid is the main diagnostic tool for CMV endotheliitis. It should be done prior to antiviral treatment or in the early stage of the disease. Decrease in viral load to below detectable level in the later stage may lead to false negative result. PCR analysis of HSV and VZV should also perform at the same setting. Hence, Chichili et al. In 2003 has introduced multiplex polymerase chain reaction for the detection of HSV, VZV, and CMV in a single ocular specimens. Other than PCR, seroantibody can also be done but may not give much diagnostic value. Koizumi's report from Japan Corneal Endotheliitis Study Group found that all the patients with CMV endotheliitis will have 100% positive value of anti-CMV IgG, but 100% negative value for anti-CMV IgM and CMV PP65 antigen. However, Goldman-Whitmer coefficient analysis can be used to differentiate the anti-CMV antibody in aqueous, whether that was from the ocular tissue production or from the serum. This test is of limited use in immunocompromised patients due to their overall low antibody production. Using both PCR and GWC analysis can improve diagnostic accuracy. Confocal microscopy may detect outside appearance at endothelium in CMV endotheliitis. The outside cell is the large endothelium cell with nuclei possessing a central area of hyperrefractivity surrounded by a halo of hyporefractivity. This picture was an autopsy photomicrograph from CMV infected kidney cells. It shows the outside cells characterized by large intranuclear viral inclusion bodies. This picture was taken from Shirashi's report in 2007. It shows the outside appearance of endothelial cells through confocal microscopy. This picture was taken from Kobayashi's report in 2012. It shows similar outside endothelial cells via confocal microscopy as pointed out by the white arrows in the third row of the pictures. This is another picture reported by Yokogawa in 2013, also shows the coin-shaped lesion endotheliitis and the outside appearance by confocal microscopy. In anterior segment OCT, the corneal endotheliitis may appear as hyperrefractivity lesion at the endothelial level. Keratic precipitates may appear as sawtooth-like protruding structures. You may also see localized corneal edema from the OCT. This picture taken from Yokogawa's report in 2014. Picture A and Picture B on the right shows the hyperrefractivity lesion at endothelial level, which corresponding to the coin-shaped lesion on the cornea. There was also overlying corneal edema observed from the OCT. This picture from Kobayashi's report in 2017, the upper picture B shows isolated KP as pointed out by the arrows, and sawtooth-like KPs as pointed out by the arrow's head. The middle row, picture A, B, and C, shows resolving localized corneal edema after antiviral treatment. The lower row, picture D, E, and F, shows resolving of KPs and corneal thickening corresponding to the progress as mentioned earlier. Specular microscopy can be used to monitor the endothelial cell density reduction along the course of the disease. Frequent reactivation of endotheliitis with significant cell density reduction should warrant more intensive antiviral treatment. This picture reported from Chu in 2012 shows an eye with post-penetrating keratoplasty with coin-shaped lesion and confocal microscopy outside appearance. The endothelial cell density was significantly reduced as evidenced by extensive catata from specular microscopy. Ganciclovir remained the main treatment modality for CMV endotheliitis. There are many treatment regimes has been used from various reports. These included ganciclovir gel 0.15% 5 times per day for 6 weeks and then tapered to 3 times a day for another 6 weeks. Another regime is compounded ganciclovir, range from 0.5% to 2% for every 2 to 4 hourly for 6 weeks, then tapered to BD to QID for another 6 weeks. More invasive treatments such as intravitreal ganciclovir 2 mg in 0.1 ml can be given weekly for 6 weeks, or stat dose, then followed by oral wild ganciclovir. Other than that, intravitreal ganciclovir implant 4.5 mg has also been used to treat CMV endotheliitis, and its therapeutic effect can last about 5 to 8 months. Some reports have stated systemic antiviral as primary antiviral treatment. Those regimes included oral wild ganciclovir 900 mg BD for 6 weeks, then tapered to 900 mg OD or 450 mg BD for another 6 weeks. Another option is intravenous ganciclovir 5 mg per kilo BD for 6 weeks, then followed by oral ganciclovir 1 gram TDS for 6 weeks. Although oral wild ganciclovir have better bioavailability, however, it also has higher incidence of neutropenia. Yet, both oral wild ganciclovir and oral ganciclovir regime has similar efficacy. There were no consensus of steroid treatment on CMV endotheliitis. Intensive steroid use may exacerbate endotheliitis in the absence of antiviral treatment. Therefore, minimal steroid amount should be used to maintain the quiescent stage of uveitis, tuberculitis, or endotheliitis. Chronic CMV endotheliitis may lead to endothelial dysfunction and corneal decompensation. Corneal transplant may be offered to such patients, but it is recommended to treat the CMV endotheliitis prior to transplant. Complete remission can be confirmed via repeat aqueous tap and PCR. Corneal graft could fail very soon if CMV endotheliitis was not treated prior to op. In post-corneal transplant patients, new CMV infection or reactivation is not uncommon. Diagnosis may be challenging due to the similar presentation in the endothelial rejection. CMV endotheliitis recurs frequently after discontinuation of antiviral therapy. In 2010, Chi-Sun-Pek et al. Described the treatment and outcome of CMV anterior uveitis. It was reported 76% of treatment response, but there was 75% of cases with recurrences. The take-home message is, do suspect CMV endotheliitis when patient presented with linear capes or coin-shaped endothelial lesion, especially with localized corneal edema, high IOP, features of PSS and FHI with frequent reactivation, or significant endothelial cell loss. PCR always required to confirm the diagnosis and prefer to do it before antiviral therapy to yield high positive result. Recurrence is very common, and some individuals may require long-term topical antiviral therapy with or without minimal amount of topical steroid. Here I thank you for your attention.
Thank you, Dr. Liew, for the very informative talk. We have some technical issue with the next speaker, so we will proceed with a Q&A session first. The first question is for Dr. Liew. Dr. Liew, there's a question. This is about your treatment. How long after treatment do you decide to do a corneal transplant? And if you decide to do a corneal transplant, what will be your choice of transplant? Will you do a PK or a DSEC?
Hi, can you hear me?
Yeah, I can, Dr. Liew.
Okay, good. First is how long of the treatment, right? I will give the antiviral for the CMV endotheliitis. Yeah, usually after 3 months of treatment, we should repeat the echo step and PCR and check whether they are still positive or negative for the CMV DNA PCR. So if they are still positive, so the treatment have to be ongoing until they are recover, and then repeated PCR is negative. That is the ideal world. Of course, some patients, they don't want to be too invasive. As long as the eye is quiet, sometimes I do not repeat. So I just stop their treatment. But in certain cases, they are so chronic, they always recurrence, and then they have a positive, the cornea is decompensated. So we have to do a corneal transplant for them. In this kind of case, I will probably go for more invasive treatment or systemic antiviral first, and then I will repeat PCR again. If it's still positive, then I may delay the surgery. So if let's say this is a visual handicapped patient, she really need need vision for that. So it's only eye, then I may do an early transplant, but with the cover of oral systemic antiviral at the same time. Yeah, so it's better in the ideal world, it should be done when the eye is negative for PCR. And what's the next question is what surgery I will offer to the patient? Of course, if it's just an endothelial dysfunction without corneal scar, I will do a DSEC for the patient. I don't know how to do DMAC yet. so yeah, I can only do DSEC. But then if the patient, the cornea is so chronic, corneal edema is so chronic, and then it forms a scar, so there's no choice, we have to do PK. Yeah. So, and watch out for the reactivation sometimes after operation. So when they reactivate, it's not a rejection, then we need to restart the antiviral regime again. Yeah. Usually such cases, I will maintain topical eye drop for lifelong. I mean, an antiviral eye drop for lifelong.
Thank you, Dr. Liew. Dr. Liew, this is another question for you. Sorry.
Wait, thank you, Dr. Liew.
Yeah. Am I answering your question?
Yeah, sorry, there's another question. Hi, Dr. Liew. If our center does not have PCR tests for CMV, HSV, and VZV, how would you confirm the diagnosis? Is there any other way of confirming the diagnosis?
This looks like a distress question from one of our viewers.
Yeah, actually, not only Sabah here we cannot do in our center, but I believe in the West, Sungai Buloh also stopped doing some PCR for CMV as well. So we can't even send to the West. So no choice. We have to look for the outsource. But you know, our government actually have not enough allocation for that. So we have to ask patients whether they are willing to pay for the test in the private or not. We can collect the sample for them here, and then we send to the private lab. So far in KK, this one lab I identify is can do this PCR test. It's a multiplex PCR. They can detect, they can check for HSV, VZV, and HSV at the same time. So so we can know what is the real cause of the corneal endothelitis. So it's always back to the patient whether they are willing to pay, and we send it to the private lab.
Thank you, Dr. Liew.
Yeah.
Since you're the only one here for this session, so there's another question for you. This is from the chat box Zoom. Yeah? Dr. Liew, what is the preferable topical steroid of choice in CMV endothelitis, and what is the frequency?
What is the one? The last question?
Topical steroid of your choice in
Yeah.
CMV endothelitis.
Yeah. I actually it depends what is available in my hospital and my center, whether but usually in the early stage of the disease, the inflammation will be more than I mean, it's not very severe gingivitis. In this kind of case, usually I don't start too hourly. I just start like QID like that. So for me, I will use Peripheral or Mesidex. Yeah, it depends what is available. Yeah, and then after a while, after 1 week, then I will taper down to like BD or OD. It depends on the inflammation situation. Yeah, because I don't want to give more frequent steroid that actually prolong the viral shedding problem. So the antiviral has to be concurrent as well to give it to the patient. Yeah.
Thank you.
Doctor, yeah.
Thank you, Dr.
Any more
Liew.
questions? Still have technical problem, right, Doctor?
Yeah, while waiting for the next presentation.
Maybe we can promote. Maybe we can promote our Facebook page. You know, we have a Borneo Ophthalmology Facebook page now. Actually, we will update our this Borneo Ocular Update 2021 video will be available in the Facebook, and also this coming website day video we will put there as well. So stay tuned and hope you all can subscribe and like that page.
Is Dr. Vanitha still around? Due to popular demand, we have a question for Dr. Vanitha from the previous session.
Yes,
Dr. Vanitha, your call back.
Dr. John have question to you, I think.
The first question is for your RCE topic just now. How do you follow up patient post debridement? And after debridement, do we pat the eye or we can just put BCL?
Okay, so post debridement, generally I don't patch the eye. Generally, I prefer to use a BCL only because it can stay on longer. And you know, with patching, sometimes they can still blink underneath the patch as well. I find they're generally quite comfortable with BCL, even with regards to pain. How will I follow up the patient? So I think one of the things is I put a BCL on. First of all, when you are debriding, it's important that you actually remove all the loose tissue. You might initially see a small area, but then when you go in, you realize that, you know, that area is actually quite large. So debride all the loose tissue and then use a bandage contact lens. For pain, maybe you can even give some cycloplegics. I always give my patient lots and lots of lubrication, as well as topical antibiotics. And I do actually give a bit of steroids as well, topical steroids. So, you know, maybe you can just start low frequency initially, and then as the epithelium heals, you can increase that. You want to keep the bandage contact lens on for a few weeks. Don't remove it as soon as the epithelial defect is healed. For the pain also, I always tell the patients when you go home, there'll be a bit of pain, you know, but just switch off the lights, you know, close your curtains, you know, just try to avoid bright lights and just sleep it off. And usually they're fine by the next day.
Yeah, Dr. Vanitha, when you polishing the cornea, right, with the diamond burr, will you avoid the visual axis area or?
No,
or
I think
just
you can proceed with the visual axis area, which is one of the advantages of using the diamond burr, because it's not going to cause scarring of the visual axis. You do get some haze, you may get some refractive change, so you want to warn the patients about that beforehand. But again, you're going to do some light polishing. You're not going to be too aggressive with it.
Yeah, I did the same thing. I do a very light polishing. The periphery I will do more vigorous.
Well, even then, if you're too vigorous, you can change the corneal topography a little bit, which can affect the patient's refraction. So, I think it's that learning to get just enough.
Thanks.
Thank you, Dr. Vanitha. Another question
Dr.
for Dr. Liew.
Haslina, lady. Sorry. Prof, okay already?
Yeah.
Yes, we are ready. I'm ready. Thanks.
Okay, now we would like to move on to the next talk. I would like to invite Prof. Madya, Dr. Wan Haslina, Wan Abdul Halim, Consultant Ophthalmologist and Corneal Surgeon of Hospital Tunku Mukris, University Kebangsaan Malaysia, to give her talk on peripheral ulcer keratitis. Please welcome.
Thank you, Madam Chairman. Let me try and open my slide. Okay, I had a slight difficulty this morning. Apparently, I would like to share as much as possible my pictures for this session, but apparently it makes my slide frozen and I cannot put it on play slide. And most of my pictures are clumped at the back of the slide. So I'm really sorry, but I will navigate through all of you the pictures later. So my talk today is on peripheral ulcerative keratitis. Sorry, I have to try and navigate down. Okay, so the outline of my slide is an overview of PUK and what is the definition, symptoms and signs. I'll line out the comparison between Moran ulcer, Terrine marginal degeneration and marginal keratitis, and I'll discuss about management. And I was planning to show you a lot of my cases to just share the experience. So when we talk about peripheral cornea, so we must understand that this peripheral cornea has no clear-cut borders. It's actually a big portion between the central 50% of the cornea and also the limbus. And it's actually an arbitrary area encompassing 3.5 to 4.5 millimeter from the visual axis extending to the junction. And because of this structure is very near to the limbus, it is also near to the highly vascularized area where you can get vessels, vascular supply from the conjunctiva and also the episcleral vessel. Why is this important? Because it can be a source of the immunocompetent cells that play a big role in this disease. So when we talk about pathogenesis, there are various etiologies that I will line out after this. So basically what happened, these etiologies has caused an inflammatory reaction at the cornea periphery. And therefore an immune complex deposition and complement activation happen and inflict and vasculitis event. And further, this vasculitis causes vascular permeability and leakages, and thus generate chemotactic factors for neutrophils, and then pro-inflammatory cytokines come in, and neutrophils later come in and actually causes liberation of proteolytic and collagenolytic enzymes. At the same time, metalloproteinases were produced by the local resident cells, and these cascade resulted in the destruction of the corneal stroma. There are many etiology that's discussed, but mainly the first one is ocular, and the first one would be that we would like to rule out is the first one is systemic, followed by ocular. So there's a long list here, but the one in red signifies the most common. So you can see here in rheumatoid arthritis, there's also an ANCA-associated vasculitis, and Morgan's granulomatosis are the most common collagen vascular diseases that can cause PUK. Additionally, Sjogren in rheumatoid arthritis, in relation with rheumatoid arthritis, also can be one of the main presenting symptom. But we must not, how I say, well, we must always remember to rule out infection causes. So if there is any suspicion of infection, we must be very cautious and try to rule out by doing appropriate investigation. So the ocular manifestation range from foreign body sensation, watering pain, and photophobia. This is due to the epithelial erosion and the ulceration that happens in the cornea. And the pain can be from mild, from discomfort to very severe, where in Murine ulcer, there's associated scleritis, therefore there will be some pain. And decreased vision is apparent when the inflammatory
Dr. Wang, sorry to interrupt you. I think your slides are not changing. Do you want to change it to a slideshow view or to the next, still at the anatomy of the cornea?
Okay, so my slides are frozen, I'm sorry. So let me share again. So, okay, so as I mentioned just now, when you talk about the etiologies, you have to remember that there's not only ocular diagnosis, but there are also systemic diagnoses. So I'm sorry because I cannot seem to play it up, my slide. So I will try and focus on the manifestation. Let me play again my slide.
Yeah, could you try to reshare it again, Doctor, your screen?
Yes, I'm trying to share where the slide is. Okay, can you see my slide now?
Yes.
Okay, so this is a case where you can see that in the top picture, this patient come with peripheral ulcerative keratitis in the form of Murine. So this is a localized condition where this patient had SMILE procedure 1 year prior to presentation. This top two picture is the same patient. So you can see that there is involvement of the peripheral cornea, and there is an ulceration that had caused thinning in this part of the eye. Okay, so in the left hand picture there is quite extensive, where there is a microperforation already happening. So you can see that the involvement in this case is quite extensive with vascularization, and in certain cases you might see microperforation. The lower picture is a patient who presented to us, elderly patient who presented to us, and when we investigated, this patient has a seronegative rheumatoid arthritis. So this patient presented to us with perforated cornea, and associated with fungal infection. When we talk about investigating for the diseases, we must remember that the outline of the local as well as systemic causes. So let me try and share with you one more slide on the differences between different types of peripheral ulceritis. So bear with me. So I'm showing you again. This is the picture. So this is just to outline the differences between a localized cause of peripheral ulcerative keratitis. One is Murine ulcer, second is marginal keratitis, and Terrian marginal keratitis, Terrian marginal peripheral marginal degeneration. So these are the most common local presentation of PUK. So in Murine ulcer, it can be young onset or late onset. In marginal keratitis, is a bit non-specific, but may be associated with underlying acne rosacea that cause significant blepharoconjunctivitis. In Terrian marginal degeneration, the patient are much of younger onset and in male. So the symptoms can be mild with discomfort and also redness, but most of patients with Terrian has minimal pain or almost no pain at all. The clinical features that distinct between these three are the configuration of the ulcer, where in murine ulcer, you can see that the epithelial defect is very significant, and that is an infiltrate, like what we see in the left-hand picture there. Okay, so there is also overhanging inner edge of ulcer, where you know that in this patient there is significant stromal destruction that precedes the epithelial defect. Okay, in this patient, there's a risk of operation, and the patient will present it with surrounding inflamed conjunctiva, but not up to the extent of scleritis. When you talk about presence of scleritis, we have to firmly suspect that this patient may have a systemic association. So in marginal keratitis, as we know, this is quite common, where you see distinct area of perilimbar sparing, and the epithelial defect may present with some infiltrate, and you also would have association of blepharoconjunctivitis. Whilst in Therian, it actually doesn't have that, overhanging edge. The defect is more sloped, and there's no clear interval. There is a low risk of perforation, and the eye might not be, most likely are not inflamed. So when we to proceed from here is for us to investigate. So investigation may be in the form of blood investigation, and anything that we do, we must first rule out systemic causes. Why? Because if you do not rule out systemic causes, patient might be at risk of a fatal condition. So if you have a patient who was not treated well, there is a risk of fatality because it's involved a systemic vasculitis. So I'm sharing with you now a slide on what are the diagnostic workup involved in diagnosing PUK, which of course starts with history and systemic review, because you need to rule out what are the associated systemic diseases with PUK, and corneal scraping may be indicated if it's dense infiltrate and suspiciously presence of eye discharge, because we want to exclude infectious etiologies. So these are the batteries or the list of investigation listed in the screen. So the next thing that we want to do, once we diagnose this patient with whatever condition that we have diagnosed, how do we treat them? So again, let me stop share and share again my slide. So treatment can be divided into medical and surgical. So medically, as we know, if the patient have a systemic condition, now even though it's a local condition, sometimes the patient might not respond just for local treatment for local causes. Patient might still need a steroid treatment, oral steroid treatment. So systemic steroids are indicated where we give, there is progression, and we started them with 1 milligram per kg per day, and there will be pulse methylprednisolone for 3 days. If it's an inadequate response or resistant, or you would anticipate the prolonged use of steroid and to prevent side effect, alternative immunosuppressive agents must be discussed early. So the indication for systemic immunosuppressants are many listed here. Severe systemic vasculitic syndromes may be indicative for immunosuppressant. If you have necrotizing scleritis and vasculitic condition, you also need to start patient on immunosuppressant concurrently with your steroid, because as you know, the systemic immunosuppressant will take time to act compared to steroid, which is more rapid, especially the IV metopred. So you have bilateral rapid progression of Moran ulcer, like the first patient that I showed just now, even though it's not systemically related, you have to start the patient on some immunosuppressant together with the steroid. So the immunomodulatory agents of choice, firstly is cyclosporine, and you can add it on with mycophenolate mofetil if it's still non-responsive, and sometimes you need to substitute it with the cyclosporine with methotrexate and azathioprine. There are patients who I have to put on steroid, on cyclosporine, and also on Celsep together. But bearing in mind that we need to ensure that one of the steroid needs to be tapered off eventually, and maintaining them on 2 immunomodulatory agent can be acceptable. Okay, but in cases where the resistance still continues, we might need to add on with an IV cyclophosphamide to further help with the treatment. There are instances where you need to give much more potent agents, such as immunologic agent. Okay, so the immunological agent can be given if you think if whatever you have done so far with the immunosuppressive, local help, and also immunosuppressant did not help with the treatment. Okay, so I'm sharing you the list of immunologics that can happen, that can be given to patient. One of it is called infliximab, adalimumab, and also rituximab. Depends on your institution. I think for a medical retina, they are more prone to use rituximab, and for conditions, immunologic conditions from the internal medical department, they would more prone to use infliximab. Adalimumab is a bit rare, but it's not available in my institution. But if there is, then you can actually discuss with your rheumatologist to start this biological agent. It is not compulsory, but it is an option. So I'm sorry because I skipped the topical treatment. So let me just go on to the topical treatment that we need to do when you treat this patient. So the medication that I discussed just now are more to systemic treatment. So you must know that whether to start together with the systemic or not. So let me show you my slide on that topical treatment. Okay, so the first one that is very, very important is for you to make sure that you lubricate them well. Okay, so lubrication is an essential treatment for PUK, because if you don't lubricate them well, the thinning will keep on progressing. At the same time, you must cover them with antibiotic because you don't want a secondary infection to happen. And additionally, you might add a topical collagenase inhibitors. In my hospital, sometimes I have to give acetylcysteine solution, 20% topical. And if you have ointment tetracycline, yes, by all means, please do start it. Topical steroid can be considered as initial therapy in milder or unilateral cases, and it's usually may be useful in a mild case of rheumatoid arthritis. But it can cause progression if you give this steroid eye drop, intensive steroid eye drop in vasculitic PUK, and especially in Morgan's granulomatosis. And sorry, this glue patching, if you have microperforation, you might also resort to a corneal acrylic glue or bandage contact lens to aid epithelial healing, and which may actually seal the microperforation. Okay, let me continue with the next one, which is the surgical therapy. So once you have exhausted your topical and your medical therapy, but sometimes you know that the progression is so fast that you have to start the surgical intervention quite early. The surgical intervention can be very minimal, such as just conjunctival resection. okay, and recession, where you just temporarily remove the limbal source of the local cellular mediators and collagenases, which is important in the progression of the disease process. If it's done early, you can resect the conjunctiva 2 to 3 mm beyond the limbus, and after that proceed with lamellar keratectomy and keratoplasty. But when you want to decide to proceed with lamellar keratectomy and keratoplasty, be aware that you need to prepare the patient on this inflammatory insult. Surgery. The surgery can be an inflammatory insult. So make sure you prepare your patient well, giving them 1 milligram per kg per day for minimum of 1 to 2 weeks. It depends on the condition of the patient. If it's severe enough, you can prepare them for 2 weeks. But yeah, I would advise more to a 1 week preparation with oral steroid. So what does lamellar keratectomy does is arrest the inflammatory process, and it allows healing. Seldom we need to do central penetrating keratoplasty because usually peripheral ulcerative keratitis only involve the periphery and not the central cornea. So these are the indications. Sometimes I do crescent-shaped lamellar graft, and then in another condition where the lesion is broad enough, we need to do a donut over, or sometimes we call it as a banana-shaped lamellar graft. Amniotic membrane transplantation can be a supplementation or adjunct to the both treatment that we give just now, which is the conjunctival recession or lamellar keratectomy. Or it can just be something that you want to put on while you wait for the inflammatory reaction to be slowed down by your oral medication. But the amniotic membrane transplantation would not work if you still have an ongoing severe inflammation of your cornea. So, and another thing, if you have a localized condition, for example, peripheral ulcerative that is due to marginal keratitis, and you see that it's all partially treated, you can resort to some sort of like conjunctival flap, even though this is not something that I practice because usually if in marginal keratitis, you may just get away with adequate topical antibiotics and lubricants. I think I've ended. I think I'm at the end of my presentation. But if you want, we can do some case sharing where I can show you pictures, Madam Chairman. Is my time up?
How many photos, Doctor? I think maybe 1 or 2.
Okay. So let me first see my slide. So I'm sorry for all these hiccups because I was so ambitious to show you my patient and I've just dig it up from my WhatsApp and all. So it takes some time to show. Yeah. Okay. So I'll show you one patient. Where this is a patient that I talked to you about having a bilateral peripheral ulcerative keratitis secondary to Murine ulcer, which is inflicted by a smile surgery. So apparently, I don't think this is a surgical procedure. The surgical procedure might incite more cascade of inflammation, but this patient has underlying Stevens-Johnson syndrome, which he experienced 3 years prior. So 3 years prior, he had Stevens-Johnson syndrome and he recovered well from it, but he decided 1 year prior to the presentation to go and do a smile. I'm sorry, I cannot edit my picture here, but I just want to show you where I did my crescent-shaped grafting on the left eye where there were persistent microperforation and we had to go in and do it. So there's a corneal, this is a corneal limbal scleral rim, which actually the remnant of every time we do a PK or something, we can actually use that to patch these patients' eyes. But it depends on also the width of the ulcer. If it's too wide, this is supposedly not practical. So apparently this patient was maintained well with 2 immunosuppressants, and we managed to bring the steroid down very low. And currently we are in the midst of tapering the cyclosporine and also the Salsap that he's been using. On the advice of proper lubrication, this patient is very compliant with the lubrication and is able to maintain his eye vision very well, and the inflammation was quietly subsided. So, and I would like to show you one more case, which is a very interesting one. So, this is a case where those who are familiar with HUKM would be able to recognize this patient. So this patient is he came to us at 30-something with a very severe condition of peripheral ulcerative keratitis. So when he came to us, the cornea was very, very, how would I say, very melty, and it involved the central vision. So we had to go in and do not only we didn't do penetrating keratoplasty, we do a whole cornea scleral patch graft on the patient. So in this patient, you can see here that there is the remnant scleral rim here. You can see that's the scleral rim that we put in together with the cornea. And can you see my picture? So, yeah, and then apparently he still progressed. And the interesting thing is the melting doesn't involve the scleral rim that we patch on him. It only involves the corneal stroma. So, as you know, the disease itself is actually attacking the corneal collagen. So this is very apparent in this patient where all the corneal graft that we patch on was also melted. And this is the second, after the second patch graft that we did. So at that second time, what we did was just transplant a whole cornea on top of the old graft and on top of his own eye, which already thinned out and melts. Okay, but apparently he still progressed. You can see here that the progression occurs at the graft host junction, where the vessels are still there. No matter what we do, conjunctival resection and recession, the vessels still go on going in and produce all these cells. So we must be careful about vascularization. So try on our best to how would I say, prevent vascularization from going in. So this patient, apparently we have to give in rituximab, and currently even though the melt still occur, it somehow stopped at one time where we had to get a lot of things. Topically, I had to add cyclosporine 1%. I had to also give tacrolimus on night, and we managed to reduce it to a quiet now. There's no more staining, even though it's still thin, but the integrity of the globe is still maintained. So sharing you the very resistant case just now. Okay, I think I'll stop my slide now. Thank you very much for your patience and understanding, dear organizer and all the participants. Thank you.
I hope your patient continues to be stable after that.
Yes.
Doctor, we have a few questions from the audience. I'll read it out to you.
Yes.
The first question is in ANCA-related PUK. Would you start steroids yourself or refer to rheumatologists? I think this is your experience in your practice.
Okay, if it's ANCA positive, we would not wait for rheumatology to start, because we know that if it's ANCA positive and there's already significant PUK in the eye, I would start myself, but I would ask rheumatologists to assist me in monitoring this patient, because this patient may develop other systemic presentation of ANCA positive diseases, such as Borneo Ophthalmology. So as you know, Borneo Ophthalmology also can attack your heart and other parts of organs of your body. So yes, I will start myself, but I will still refer to rheumatologist to help me monitor this patient.
Thank you, Doctor. Another question for you, Prof. How do you prepare a patient with PUK who needs to undergo cataract surgery? Is there any special consideration or perhaps to start any medication?
Okay, as I said just now, a surgery is an inflammatory insult. So you want to cover this patient with adequate protection, immunosuppressant. So 1 week prior to starting a surgery, even though it's a cataract surgery, especially it's cataract surgery, because you are going to enter through the cornea. And even if you enter through the sclera, there is still risk of inflammation that will cause PUK to worsen. So you need to cover them with 1 milligram per kg per day of steroid. I would say minimum 1 week prior to treatment, but ensuring that patient has been quiet for a while, meaning that for me, I would wait for 6 months minimum before I suggest any surgery for the patient. Any unnecessary, I would say anything that is not related to the PUK to be done for the patient.
Thank you, Prof. I think there's another very interesting question here. In perforated PUK due to rheumatoid arthritis with concurrent fungal ulcer, would you titrate the steroid treatment?
Okay, that's why this is a challenging thing, because you have inflammation in one hand and at the same time you have infection in one hand. So that's why investigation and making sure what's your microbial agent that caused the infection is very, very important. So adequate biopsy, for example, if you do need to do corneal scraping, you do corneal scraping. There was one patient that I showed to you just now, an elderly lady who come to us with seropositive rheumatoid arthritis and perforate with fungal infection. We did not start steroid in that patient apparently. We concentrate on treating the patient with antifungal first. But once we see response in the antifungal, we discuss with the patient that the possibility of concurrently starting the patient on steroid. So that patient was very lucky. After a week, I would say after several days to not even a week, we can see a rapid contraction of the hypopyon, the infiltrate become much more less dense, and we are confirmed that the infection was confirmed, and we covered her with a very broad antifungal therapy as well. So once we see treatment, when we see a progression and regression of the infection, we tell her that we want to start with introduce steroid, and but we monitoring is very important, so we keep the patient in the ward, monitoring her maybe twice a day, see the firstly response towards topical steroid. I would say try and challenge her with topical first. So we challenge her with topical first, we see some more improvement, and we start the patient on oral steroid. So the steroid was not started immediately. The steroid was only started after we do the surgery. So the surgery was done kind of like tectonic therapeutic kind of surgery where we do a patch over the perforated area. So once we see resolution of hypopyon, I think we started the steroid about 2 or 3 weeks after that. Then only we maintain on the steroid, and slowly, because it's a seronegative RA, we introduce cyclosporine as well, which is started I think about 6 weeks later, as we don't see any more progression of the fungal infection. So yes, you can try and introduce or firstly challenge the infection first with steroid. If there's a good resolution still seen, you can start oral steroid, and introduce it with caution. Yeah.
Thank you, Prof. So that's all time we have for Q&A. Now we are at end of our virtual meeting. Behalf of Borneo Ophthalmology update team, we would like to thank all speakers again for spending their precious time with us and sharing their knowledge. for the past 2 days. I also would like to take this opportunity to thank our Head of Department, Hospital Queen's Elizabeth, Dr. Sheena Mary Alexander, for her continuous support. Our BOU chairperson, Dr. Liew, for his expertise and encouragement. Last but not least, all the HQE staff and also our dedicated BOU team. This meeting will not be successful without your teamwork. To all participants, thank you for joining, and do visit Sabah once this pandemic is over. Dr. Liew, do you have any last words to say?
Nothing much. Just once again, I want to thanks everybody, all the speaker. Yeah, I can't name everybody. So thanks to all the speaker, all of you, to make this event success, and also thanks to the participant, and very our response is very well. So a lot of attendance as well. So this means our quite success in this update. So yeah, I think that's it. Maybe we can take a group photo. Hope everyone can turn on your picture. Yeah, so we can put in our Facebook.
We also will be displaying the QR code soon, and it's already in the chat box, so participants can always scan it for your CPD points later.
Yeah, I can see Dr. John, Dr. Cheng, Dr. Vanitha. Okay, so 1, 2, 3, we take our photo now. Okay. 1, 2, 3. Oh, okay. Okay, we are done. So I think we dismiss here. Okay. So hope to see you all again. Bye, everybody. Oh yeah.
So
The,
we'll be sharing.
yeah. The QR code. Yeah, we're sharing in the group later. We will send the the certificate to all of you.
Let's see.
This is the QR code for the MMA claiming of the CBD. Yeah. For those in private, you need this. Yeah.
you.